Good evening, everyone. I'm Dr. Rohan from first year PG from SIMS Hospital, Chennai. I'll start with my case. So, here I present a case of a 43-year-old gentleman. He was first seen by our department in August 2018. He had presented with complaints, in his own words, as chronic indigestion. He complained of poor appetite, early satiety, postprandial, some vague upper abdominal discomfort, vomiting which occurred few hours after meals, which was non-bilious and mainly contained undigested food particles. On this background, he had some complaints of an acute onset pain in the left lower abdomen, radiating to the back, with multiple episodes of non-bilious vomiting for 3 days. There was no history of any weight loss, hematemesis, melena, hematochezia, jaundice, heartburn, dysphagia, bloating, any altered bowel habits, hematuria, or fever. He had a history of chronic NSAID use on and off for abdominal discomfort. He was a known diabetic, hypertensive for 3 years on regular medication. There was a history of multiple hospitalizations under various departments since the last 1 year. I'd be coming to that. And he denied any addictions. There was no significant family history. So as we see, he was first seen by the physician in 2017 July when he was evaluated for dyspepsia. Gastroenterologist had evaluated him that time, and an endoscopy had shown an esophageal submucosal mass, which on endoscopic ultrasound on the biopsy showed evidence of leiomyoma, and it was left alone since it was asymptomatic incidental finding. In October 2017, he had an episode of severe acute gastroenteritis for which he was hospitalized and treated. Then in February 2018, he had an acute onset pain in right lower abdomen. On clinical and imaging features, he was diagnosed to have appendicitis and he underwent a lap appendectomy. Then in April 2018, he had an acute onset history of fever, cough, hemoptysis and dyspnea for 3 days. The CT chest had shown bilateral lower lobe infiltrates with basal atelectasis and paramnemonic effusion. He was diagnosed as community-acquired pneumonia and treated with piperacillin, tazobactam and azithromycin. So here we see on this admission, he was well built. He's on the overweight side. His BMI was 30 kgs per meter square, and his vitals was stable. Abdomen was soft. There was mild left lumbar tenderness. The other systems were normal. So on investigations, just to summarize, it showed evidence of acute kidney injury with elevated serum creatinine and blood urea levels with a raised total WBC count. Urine routine analysis was normal. The culture did not show any growth. Other baseline investigations were absolutely normal. CT scan of the abdomen was done, which showed evidence of perinephric fat stranding and a microlith in the left kidney. There was no obstructive changes. And incidentally, a focal heterogeneously enhancing wall thickening with ulceration and calcification in the posterior wall of the antrum of the stomach along the lesser curvature was noted. So the impression was a background of a left pyelonephritis with an incidentally detected gastric ulcer and an antral submucosal lesion. Query fibro-inflammatory according to the imaging characteristics. So here we see the lesion, the gastric lesion on the cut section and on the coronal section. So here we see the antral submucosal lesion on the cut section and here on the coronal section. So the patient was treated symptomatically with IV fluids and antibiotics. The acute kidney injury, which was presumed to be like a pre-renal azotemia with query NSAID-induced tubulointerstitial nephritis because of the history of chronic NSAID use or pyelonephritis, was settled with IV fluids and antibiotics. It was then decided to evaluate him for the incidentally detected gastric antral submucosal lesion. So the endoscopy done by our department showed an antral submucosal lesion along the lesser curvature with a central excavated ulcer. The biopsy showed evidence of mild chronic gastritis with focal inflammation and ulceration, and the endoscopic ultrasound showed a submucosal mass lesion arising from the muscularis propria, and the biopsy, unfortunately, there was insufficient tissue, so a diagnosis could not be made on that. So the provisional diagnosis was an gastric antral submucosal mass lesion. The etiology still was not detected. So the endoscopy here, as we see in the first picture, shows the esophageal submucosal lesion, and the second picture, which you have already seen, the endoscopic ultrasound picture in the bottom. We sought the surgical gastroenterologist opinion, and in view of gastrointestinal stromal type appearance of the lesion, without any evidence of any other intra-abdominal lesions on CT scan, it was decided to do a laparotomy for the resection of the mass lesion, and on table the laparotomy was converted to an open surgery, and he underwent partial gastrectomy or mass resection. The operative findings showed that there was a 7 by 5 centimeter mass in the greater curvature of the stomach, extending over the posterior wall up to the lesser curvature. The mass was adherent posteriorly to the mesocolon. The patient showed symptomatic improvement after the procedure, and he was discharged. So later on, this is an unexpected finding that we got on the resected biopsy of the resected specimen. It showed a fibroinflammatory lesion with diffuse lymphoplasmacytic infiltrate. So here we see the lesion. So what we see in this lesion is this is mucosa. This is the muscularis propria, the submucosa. We see dense fibroblastic proliferation. There is pericapillary infiltrate of cells. So on the magnification here we can see some plasma cells and lymphocytes. Plasma cells are these cells which have an eccentrically placed nucleus, and lymphocytes are the small purple colored cells. So we can see the inflammation extending. This is the muscularis mucosa, muscularis propria, and the inflammation is extending up to the muscularis propria. So the course after discharge was that 4 months later he was readmitted with us with again similar complaints of an epigastric pain which is continuous, unrelated to meals, associated with non-bilious vomiting, and this time he had lost weight around 12 kgs. As I forgot to mention, So the lesion on biopsy, and then later immunohistochemistry was done, which was positive for IgG4 type of cells. And serum IgG4 levels subsequently done were elevated. So a diagnosis of IgG4 related disease was made. So after discharge, he was followed up 4 months later when he presented to us an OPD with similar complaints and a weight loss of around 12 kgs. This time the abdomen was soft, non-tender, there was no guarding or rigidity, and baseline labs, amylase lipase levels were normal. We did amylase lipase because IgG4 disease, as we know, commonly presents with autoimmune pancreatitis or pancreatic head lesions. So the endoscopy done this time showed a submucosal lesion which was previously there, and at the site of operation there was a linear gastric ulcer with a deep excavating ulcer in the second in the duodenum. So we started on pantoprazole infusion with sucralfate. This was thought to be a recurrence of IgG4 related disease, and thus we started him on steroids. So during hospitalization he was on IV steroids, and then he was which was later on changed to tablet Visolon or prednisolone, and along with that an immunomodulator in the form of azathioprine was started. His symptoms settled over the next few weeks. 2 months later he was readmitted with us with similar complaints. This time he was on a tapering dose of prednisolone. The endoscopy done this time showed an excavated clean based ulcer in the antrum at the resection site and a clean based duodenal ulcer, and the histopathology showed marked reduction in plasma cell infiltrates in the gastric mucosa with but H. pylori was detected. Serum IgG4 levels also had markedly reduced. It was 4.54 to begin with, it had come to 2.71. The normal level is up to 1.35 gram per liter. So oral steroids and azathioprine was continued. Since he continued to have pain, he was hospitalized with us for a long duration, and various forms of pain palliation was tried in him. He was initially on tramadol, fentanyl, oral opioids, pregabalin, which didn't work. Then we shifted to an erector spinae block. He also required a radiofrequency ablation of the dorsal root ganglion with a celiac plexus block. This was followed by an epidural analgesia with bupivacaine. So we can see how severe the pain was for this patient. He was discharged. Again, he was readmitted after a month, and this time an endoscopy was repeated. The endoscopy showed some healing of the ulcers, the gastric and the duodenal ulcer. The histopathology showed very few plasma cells. So the diagnostic dilemma at this stage was this an IgG4 related disease in remission? If not, should we proceed to the next line of management, that is adding an anti-CD20 molecule, that is rituximab, or were we missing out on some other condition? So we did a CT abdomen with contrast, which showed retention of the contrast material and distension of the stomach. We also did a gastric scintigraphy study, which showed delayed gastric emptying. So the diagnosis made was like a post-operative gastroparesis. This time he underwent gastric antral resection with truncal vagotomy and a gastrojejunostomy. He was last followed up in April 2019, this month itself, and he's asymptomatic. He has regained appetite and weight and is doing well. So, as we can see here, the gastric emptying study, which shows retention of the technetium 99 in the proximal parts of the stomach and less than 50% emptying, as we can see. So, this is a literature review of IgG4 disease, a related disease, basically presenting as isolated gastric lesions. There have been some 9 case reports all over the world in English literature, and in all these cases we can see, just to summarize, that all of these lesions were diagnosed post resection.
Finish in 1 minute.
Yes. So these cases were diagnosed post resection, and in all these cases the preoperative diagnosis was either a gastric malignancy or a GIST, and in a few of them serum IgG4 levels were elevated. And so this is one thing. So our experience so far, in the next few months we also saw one more case of similar case, which was again on resection, was diagnosed to have IgG4 related disease. So the message would be, although IgG4 related disease itself is a rare entity, mainly presenting as autoimmune pancreatitis, mainly in males, and females it may present as salivary gland involvement. It can also present as gastrointestinal submucosal mass lesions. So when a patient has a history of multi-system involvement of doubtful etiology dispersed in time, IgG4 related disease can be considered as a differential diagnosis. Surgery may not be the final cure, since it's a multi-system disease and it is known to have relapses and remissions. Monitoring the disease remission continues to be a challenge, as we could see in our case. We could not exactly tell whether it was a disease remission or whether the disease was continuing, and hence we had to try various investigations to ultimately reach our diagnosis. Thank you.